This includes Andrew Bunny, who will be giving his SIR presentation focusing on awareness and interest of IR among medical students, and a panel discussion that includes Alok Bhatt, Nikki Zimmerman, and Erica Alexander, all instrumental in establishing models of IR student education, not only at their home programs, but regionally and nationally as well. We will follow the webinar with a Q&A session where we can answer any of the questions that you may have. So just an overview of the agenda. Hopefully at the end of this webinar you'll gain some insight into the importance of IR student education and discover some new ideas on how to promote IR at your own schools. Firstly, though, I'd like to invite Dr. Vatican Cherry, faculty advisor to the SIR Resident Fellow Section and Medical Student Council, to provide some opening remarks on what really keeps us motivated towards continuing IR student and resident education and why we feel this is so vital towards sustaining the specialty. So, Dr. Vatican Cherry.
Great, thank you. Can everyone see my my desktop? Hello?
I just gave you presenter privileges, Dr. V. So good to go.
All right. Can people see it?
Yep.
Okay. All right. So I'm going to get started. So welcome, everyone. I'm going to have to get out of here a little bit sooner than I'd like, just because I have a patient case left. So I'm going to talk about kind of what Nick Chadwick, thank you, Nick, for organizing that. I think this is timely with all the kind of avenue of what's going on and why higher education at the medical school level is really critical, and resident and med student level is really critical. Why is it not forwarding? Okay, so really this is truly an evolution of a specialty, okay, and beyond that, it's really the evolution of medicine. So vascular and interventional radiology, it's basically minimally invasive therapy. So when you break down therapeutic options for patients, it really comes down to three things: medical therapy, interventional therapy, whatever organ it may be, and surgical therapy. And so this interventional therapy is relatively new. So again, this is an extremely new specialty. It's in the mid-1960s that interventional radiology truly became a specialty, and that was when Charles Daughter, the father of interventional radiology, performed the angioplasty on a patient, okay, and had durable results. It's so new that most patients, and in fact most doctors, are unaware of what we can offer, and certainly medical students have no idea what we do. Okay, and unfortunately, a lot of medical students go through training and then they find out about interventional radiology far too late. So that is something that we need to kind of rectify. And so it really is important to educate medical students, not only just so that they have the option potentially going into it, but also they can identify things that are not classically taught in medical school as options for their patients. And I think that's really important, so because those med students will ultimately become primary care doctors or specialists, and it's important that they know all the options in minimally invasive therapy that are available to their patients. And so I think that's another key thing. So IR-DR residency is a new thing that was developed by the American Board of Medical Specialties, where interventional radiology is the 37th specialty of medicine, equivalent to internal medicine, general surgery, et cetera. So again, in September 2012, this became the fact. The American College of Accreditation College of Graduate Medical Education, they are also developed that designation in 2013. And this is key. So we came from a field of diagnosticians or diagnostic radiologists who really aren't truly, majority are not necessarily interested in patient care. It's not their primary endpoint. And their interest in diagnosis is not necessarily therapy or evaluation and management of patients, to a specialty that's really highly focused on it. And that's why they developed the specialty. We're now clinicians who must perform inpatient consults, run outpatient clinics, we admit our patients, we provide focused clinical care, and we have longitudinal follow-up. In fact, many of my patients are following for life, and that's critical to provide quality care. So when you're doing minimally invasive therapies in interventional radiology, in order to provide quality care, that's what has to be the case. And the American Board of Medical Specialties recently acknowledges, and they recognize us as, like I said, the 37th primary specialty of medicine. And so that's why we have this training paradigm. This is again from the ACGME site. It is really critical that we have adequate training in diagnostic radiology because that allows us to not only diagnose, but helps us to do the treatments and to do the kind of targeted therapy. Okay, so we have to be competent in both. So that's tricky to combine, diagnostic training and interventional training in that paradigm, in that time frame. And so this is what the ACGME, the ABR, everyone wants to do to facilitate optimal patient care. And so we have to make sure you're trained appropriately. Current training is not adequate to train an interventionalist to do what is needed for them to do to treat patients properly. So what does the new IRDR residency entail? A year of clinical medicine or surgery, 2 to 3 years of basic diagnostic training with integrated imaging and clinical rotation, integrated interventional radiology and clinical rotations. And their final 2 years are really focused on interventional and clinical rotations with outpatient interventional clinics, admitting services, consultations, and like I said, a mix of therapeutic clinical rotations. And this is kind of a grid. And this is what you really want to kind of be focusing on as you as a med student are looking for options training, or if you as a resident are looking for, how to kind of transform your own residency program to reflect this. So when is this going to happen? Well, 2016 is probably when medical students can apply for interventional residency, okay? And, fellowships will potentially start to slowly be phased out, or, in the next 7 years after that, so 2020, 22, 23. So as far as programs, Nikki Zimmerman is going to be going to the University of Virginia, but this is certainly one of the most well-established clinical pathway programs. University of Michigan has just established a program. They've already accepted a couple people. And then University of Colorado also converted their direct pathway to a clinical pathway, and they have their first in Ohio State and Kaiser. We don't have a 6-year program, but we have integrated residency during the PGY 5-year and rotations, clinical rotations, et cetera. So we're kind of set up something of a similar phase for trainees. So really, the bottom line is patients, students, and physicians all need to be educated about these new and less invasive alternatives, and really ultimately for the purpose of patient care. Students considering surgery or surgical subspecialties such as ENT, urology, ortho, or plastics, etc., or vascular, what have you, should also be educated about this new option for training and consider vascular interventional radiology early on. So it really is important to get out to them, and I know the Med Council has done a great job in setting up 1st and 2nd year lectures to medical students, 3rd and 4th year electives to medical students, research electives, and the regional IR outreaches, etc. And I think that's really critical in moving forward. So if you have any questions or want to learn more about it or get involved, here's my email, gvatican@gmail.com, gvatican@gmail.com. Thank you. Hello?
Hey, Dr. V, I think they're going to transfer you off here.
Thank you.
Hey, Nick, how we doing?
Good. Can we pass it on to Andrew Bunny?
Yep. All right, Andrew, you are now the presenter. If you want to go, I don't know if you have any slides, but you should see a little pop-up. Yep. All right, University of Minnesota. Hey, Andrew. Andrew, we might be having trouble hearing you. Can you guys hear Andrew?
I cannot, no.
Yeah.
No, neither can I.
Andrew, we're having trouble Hearing you.
Yeah, I can't hear him.
Okay.
If there's an issue, I can just go and come back to Andrew.
I was gonna say, who's next?
We can go to Alok.
Yeah, I'll shoot email. Alok, I'm gonna make you the presenter. Sorry about that, folks. We'll get back to Andrew in a bit. All right, Alok, you're now the presenter.
All right, everybody. Thank you for calling in again. And thanks, Nick, for hosting this webinar here. I don't want to leave the webinar. Just want to minimize that.
I've been trying to figure it out.
Oh, Andrew?
Oh, Andrew, you're in.
Oh.
Okay, well, why don't you take the reins over again? We can hear you now.
Ladies and gentlemen, that was Alok. All right, I gave you back the screen, Andrew, so.
Okay. Well, you guys can hear me now.
Yep.
Okay. All right. Well, I'm going to kind of pick up on a lot of things that Dr. V was talking about and the need to really teach medical students. And I gave this presentation at SIR this year in San Diego. And the presentation is awareness of an interest in interventional radiology among medical students. Just so you guys know, I'm a fourth-year resident right now at the University of Minnesota. Okay. No financial disclosures. So the purpose of this study was to gauge interest in interventional radiology as a specialty among medical students and to assess medical student awareness of the scope of IR practice. To accomplish this, an anonymous 21-question survey was emailed to the medical student body at the University of Minnesota on September 2013. The survey itself is divided into three parts. There's a brief part about demographics, and there's a part about interest and self-reported familiarity of interventional radiology, and that was using a 5-point Likert scale. And then there was a knowledge assessment. Now, the knowledge assessment was a 6-question quiz. Each question was phrased, from the following, which procedure is performed by an interventional radiologist? And each question was kind of subdivided by organ system. So there was a vascular question, a GI question, MSK question, and stuff like that. So here's an example of the questions. The first question is one of the 5-point Likert scale questions, and they all were the same idea. The first two were different degrees of negative, the first one being the most negative, and the middle one was kind of like a neutral, and then 2 positive responses. And this question here was the question used for thoracic. So the answer here was CT-guided lung biopsy. So a total of 329 students completed the survey, and the results were analyzed using a paired t-test. Now, there was a relatively even distribution among all years of medical school, with some more females than males answering the survey. Everyone who answered it was under the age of 35, with most being between the ages of 20 and 25, and majority identifying themselves as Caucasian. The overall interest in interventional radiology averaged to not at all to little bit, or like 1.8 out of 5 on the Likert scale. The lowest level of interest was seen in the 4th-year medical students. This was compared to overall interest in any procedural specialty, which was somewhat interested, or 3.0 out of 5. Interestingly, there was an increased amount of interest in IR among men when compared to women, but when looking at interest in a procedural specialty, there was no significant difference in interest between men and women. And of the few students who took diagnostic radiology rotation, there was no change in interest in IR. When asked if they felt familiar with interventional radiology, they answered on average somewhat aware, or 3.1 out of 5, with an increasing trend per year. Now on to the quiz. So the overall quiz average was 33%. There was an improved performance per year in medical school, with the highest average seen in the 4th years at 41%. The best performance was seen when answering the neuro question, where 72% got the right answer, and the worst was seen in vascular, with 11% getting the right answer. The 1st and 3rd-year medical students who said they felt more familiar with interventional radiology, so they either said they agree or strongly agree that they're familiar with IR, they did score slightly better on the quiz. But the second, like by slightly better, I mean about 7% or so. The 2nd and 4th-year students who said they felt more familiar with IR did not have a statistically significant increase in their score. The 3rd and 4th-year students who took a diagnostic radiology elective did perform better than those who had not. And students who had any interest in IR diagnostic radiology, or procedural specialties had no significant change in their quiz scores. So in conclusion, there is a low overall amount of interest in IR as a career choice among medical students. There's a poor overall understanding of the scope of IR practice among medical students. And medical students, or at least first and third years, who felt very familiar with IR only demonstrated a mild increase in knowledge compared to those who felt unfamiliar. And like we had said before, this knowledge deficit needs to be addressed in order to educate future consulting clinicians and to recruit exemplary students into the field as we move towards this primary IRDR certification that Dr. B was talking about. Now, before I continue, I just want to say there's a lot of limitations to the study. You know, it's a single institution study. There are a couple of things I would probably go back and change. Like, I think one of the reasons that the neuro question had such a high % correct was because it was the only answer among all of them that the answer choice was all of the above. And I noticed that if they didn't really know the answer, they probably chose all of the above or none of the above. So I probably would just get rid of all that altogether. But if we really wanted to take this further, we could probably do a more national level survey. But I think it demonstrates the point. I don't think a national level survey would be that different. But the question is, what do we do about it? So the RFS Medical Student Committee has put together an IRIG cookbook. And it's essentially a guide on how to start, maintain, and support your own IR interest group with the goal to help start active IR interest groups across the country. An active IR interest group, we think, is a great way to introduce the field to students in their preclinical years of medical school and hopefully drum up interest for people to get into the field. The IRIG cookbook has a lot of information on it. It has stuff about how to establish an IR interest group, how to work with an already established diagnostic radiology interest group, different strategies to obtain funding, how to advertise within your medical school, different ideas for meetings, and how to create opportunities for your members. There's several lectures that you can give, and there's also a section on how to get involved nationally with SIR. So there was a collection of 13 lectures put together by medical students, residents, and attendings, and it follows the SIR curriculum for IR fellows. So these are all subjects that SIR feels should be known by anyone who's going into the field. These lectures can be supplied to attendings or residents who would like to present to the IR interest group and will help them cut down on the time needed to prepare. So hopefully, just by saying, hey, we have a bunch of lectures that you guys can already just present from, you can get more residents involved and attendings involved. And can be given at noon, lunchtime, in the afternoon, whichever works for your institution. All right, so that's all I got, actually.
All right. Thanks, Andrew. Alok, you're going to be next, so I'm going to move it over to you.
Yeah.
All right.
Thank you, sir.
Yep.
All right, everybody. So I'm going to add to that and hopefully share a little bit of my experience with establishing this IR interest groups. I sort of established my first one when I was a fourth-year med student at Ohio State. As a resident, I've made one at University of Southern California, and I've had a hand in helping kind of establish a lot of these around the country. So hopefully I can sort of add value by sharing my experience here. But to kind of reiterate and expand upon some points that have already been discussed, I want to say a couple things. You know, so interventional radiology, there's a sort of a classic story about people who have heard about it or in it, okay? And those that are already doctors, so for example, residents or even attending, those that are IRs often say, you know, I was going to be a surgeon until I stumbled onto IR, and I was wowed by what I saw, and then I couldn't get enough. And those often that don't go into interventional radiology, when they learn about it down the road, it's pretty common to say, well, you know, I didn't know about IR until my fourth year of med school. And Andrew, your survey showed just that fourth year med students are disinterested or whatever because maybe they just haven't heard about it. And a lot of times they say, you know, I just wish I knew about it earlier. Now I'm stuck in, you know, any other field of medicine, whatever. On the flip side, many med students often say, you know, I would go into IR, but, and actually this is an important distinction, right? Because the end of that sentence really depends on your audience. And on one hand, you'll have a group of med students that say, I would go into IR, but those that don't want to pursue IR, there are those that don't want to pursue IR because they want to go into diagnostic radiology. And then there's a second half of med students that don't want to go into IR because they want to pursue another clinical specialty, okay? So with all of our efforts that we're trying to make right now, the key is which half of these med students do we want? And our target audience, sort of to put it bluntly, is this second group. We want those that are pursuing other clinical specialties to go in IR. We want to expand our recruitment pool because there's sort of several key reasons, and the reason is this. Right now, IR is undergoing this enormous cultural, fundamental training paradigm shift in interventional radiology. And it's gonna be hard, and it's gonna face sort of a rocky road. But I think with young people going into the field, it'll make it a lot easier. And really, we're seeing the transformation from technician to clinician, from subspecialist to primary physician, where the IR is sort of the buck stops with the IR, and then finally, sort of a focused problem solver to, hey, I have a GI bleed that I couldn't scope or whatever, send it to IR. To really a disease expert. So, hey, there's a GI bleed, go ahead and call IR in addition to calling gastroenterology. These both are disease experts in treating gastrointestinal bleeding. Okay? And, you know, the important kind of thing is when you talk about med students that are interested in IR, and when you ask them, hey, as we did, this is a survey of 65 med students, we asked them what they were thinking about. When you ask them what they want, very rarely are they considering interventional radiology versus diagnostic radiology. And in fact, in our survey, the top 3 specialties of choice were IR, vascular surgery, cardiology. 4th was some other sort of surgical subspecialty. And then 5th on our list was diagnostic radiology. So really, we're trying to recruit, and we're competing with other specialties rather than diagnostic radiology for our recruits. And in fact, you asked them, if it weren't for IR, would you still go into diagnostics? About half of the med students that we surveyed said no. So this is great, right? Because we actually want the people that want to pursue IR for the sake of IR. Okay? So how do we do it? And we've been talking about this for a little bit today, and it's really at a grassroots level, right? It has to start with trainees because SIR is going to supplement efforts from sort of the top down. The big dogs, the big guns. They're going to be doing what they can from a program and institutional and national level, and we have to provide the demand at a very local level. Okay? And the best way to do that is form these IR interest groups. And when we say IR interest groups, we specifically mean interest groups that are independent of diagnostic radiology, and independent is the operative word here. And you know, I think the key point there is that radiology and interventional radiology attract two different subsets of students, and that's important. Okay, people interested in IR tend to have a lot more in common with interventional cardiologists and surgeons and so on and so forth, rather than diagnostic radiologists. What we want is med students that want to sort of take primary responsibility for their patients from the start to finish of their care. Okay, so this is how I did at Ohio State. I was 4th year. I just sort of decided to go into interventional radiology. I emailed my entire med school, right, because I didn't want to go through my diagnostic radiology cohorts because they only had probably they only did have a small subset of the student population on their listserv. So I just emailed everyone in my med school. I recruited a faculty advisor. I was lucky enough to have some mentors in my local institution, which was great. And then I got a resident involved. And I think having a resident involved is key. So at your institutions, I think you need both an approachable faculty advisor and a resident that's motivated to get along, or get involved, rather. And it's important that both be approachable because I think, you know, if they're not, we can actually have the opposite effect and turn med students off. I tried to get as many med students involved as officers and get them in leadership positions as possible. I think they're more likely to get invested in that way. And oftentimes, you know, as sort of a resume builder and things like that, I was, as a 4th year med student and my resident, it was our job to kind of make sure everyone was following through with their commitments. But if they did a good job, we kind of gave them a title so that when they applied to residency and fellowship, we actually helped them. And I think people appreciated that. We became recognized by our med school. So the IR interest group was an official interest group at Ohio State and is an official interest group at University of Southern California, independently of our diagnostic radiology group. Funding, you know, this is a plus or minus, right? Because you do need money to have lunches and so on and so forth. At Ohio State, we had a lot of trouble getting money, so we decided to keep it budget neutral. It turned out that when I offered to pay for lunch for you know, the 30 med students that showed up, my attending was like, no, there's no reason you should be paying. You know, here's the check to cover the cost. And I think a lot of attending fellows and residents would be willing to put that up. At University of Southern California, just by virtue of being recognized as a group, we got $500. So right off of that, we have some sort of funding to go off of. Okay. The key is, though, being as budget neutral as possible so you're not sort of tied to funding resources. And then the other thing is, now you have this IR interest group. Now that you've kind of established it, what do you do with it, right? And it's hard not to get caught up on the details, but the take-home message is figure out any way possible to get interventional radiology in front of your target audience, which is med students that are interested in surgical and non-diagnostic radiology specialties, right? Because we're trying to expand our recruitment pool. And at Ohio State, we try to have meetings every 2 months. We had 2 sort of key lectures, right? We had a charismatic person come and talk about the introduction to interventional radiology. And then we had a broader topic, the emergence of interventional medicine, where we talked about a little bit about the history of IR, frontiers in interventional radiology, where this field is expanding, and people really resonated to this, right? Nobody knows that, IRs can be involved in OBGYN sort of issues, from fibroids to adenomyosis to neurosurgical cases with aneurysms and spine injections and kyphoplasties or chemoplasties, so on and so forth. So this is something that was really popular. We also made sure to collaborate with other interest groups, right? Because this is key. I think that people, when they initially hear of interventional radiology, they, by virtue of the name, think that it's associated with diagnostic radiology. Well, to get kind of around that, what we did was hosted events with our sister sort of interest groups, right? So we invited the surgery interest group and hosted an event with them. And this is actually a great idea because, one, we're getting to this group of med students that are interested in more clinical specialties, and 2, we are sort of dealing with the funding issue, right? Because you can go have these with the surgery interest group or the OBGYN interest group or the vascular surgery interest group or whatever, and you can sort of split the cost, and that makes things more economical. The other things that we did, we were fortunate enough to have an ultrasound lab at Ohio State, so we had procedure workshops that invited med students down, show them the ropes, and show them very basics about ultrasound. We'd have a little suturing workshops, pros and paras, and then after each of these little workshops, we'd have an IR-related lecture so that they're hearing from interventional radiologists about interventional radiology. There's no reason another subspecialist should be educating med students about what we do. I think that's important. I've tried to get as many med students as members in SIR as possible. This is a form, and I think that after this we can get this form out to everyone on this call. It's a free online application for med students to become members of SIR to get the journal and online access to SIR-Cloud and everything like that, totally free. To get our news and all that. So there's no reason not to be, it's the easiest thing to fill out. There's no reason not to. So if you guys would sort of form these interest groups, I encourage you guys to send this out to your med student cohort. The other things that we tried to do and we did was, I think one of the key things was actually setting up an IR elective. Okay, so do a month-long longitudinal elective. If you can't do that, set up shadowing opportunities or just get med students in the interventional radiology department to see what we do. I think I think IR sells itself. So as soon as you expose them, I think it'll take care of the rest. We try to set up research opportunities where they could sort of produce academic work and show their interest. We had med student lectures given by interventional radiologists. So that 14 or 13 lecture series that you saw earlier, that was born by our efforts to get interventional radiology involved in the preclinical curriculum. I had one of my attendings be able to talk about GI bleeding and so on and so forth, case, tips, all that stuff that we could that we can offer in GI bleeding. It was really popular, and we got invited as part of the regularly scheduled curriculum. Everything everything that we're doing here is about informing med students about the new IR residency, right? Interventional radiologists are clinicians. You've heard this over and over again. They're clinicians who can image, not imagers who can sometimes treat patients. That's the key distinction. The key points that I try to tell med students, and this is these are things I firmly believe, this is what I think med students should know about interventional radiology, that there are 3 ways to treat people. There's medical treatment, there's surgical therapy, and now there's interventional therapy. I think interventional medicine, all of it, from heart caths to anything else, from EVARs, TVARs, all that stuff, 100% of that was pioneered by interventional radiologists. And unlike any other field, IRs have the capacity to diagnose on imaging, treat medically, and follow, as well as procedurally and longitudinally follow their patients. And the great thing about IR is you're going to do this across every system, right? That's a key point to tell across. If you go into orthopedic surgery, you're going to be the knee guy, you're going to be the elbow guy, you're going to do one joint. IR, you can invent and innovate, and your career will be really, really rich and diverse. I think that less invasive techniques are only going to become more common, so IR's role in patient care will only continue to grow. I think that IR is a rapidly transforming clinical specialty, and people like the people on this call, we're really going to be leading the way. I think that's critical. I also tried my best to ensure every med student I ran into to not let diagnostic radiology training scare them away. I think it's easier now, actually, with the IR residency. Any Med 1 should be able to apply it to IR residency when they apply for residency. As far as non-sort of alternate pathway people, they can go to programs like Kaiser and Ohio State that have set up, up to 16 months of IR within their diagnostic radiology, so they'll get that clinical training. I think bottom line is that no other field in medicine has more potential for growth and more potential for innovation than interventional radiology. A couple sort of pieces of advice, just keep track of how many individual students you reach. Get the contact information of your IR interest groups and emails of each attendee to the Med Student Council. We'll help you reach out to them. We'll help send out newsletters and things like that to keep them informed and keep them engaged. Some obstacles that you may face, and I did face some of these, is both from the med school level and your program level. I had my diagnostic radiology attendees ask me why I wanted to form a separate group. You have to have a politically correct and appropriate answer for that, because it's a fair question. You can't say, well, I think that, you have to sort of be politically smart about it, right? So at University of Southern California, if you have a separate group, you get more money. So I said, well, this is a way to double our funding, and that was the end of that conversation. One of our med student members, their med school said, why do you need a separate group? It's a part of diagnostic radiology. Actually, by definition, it's not. It's its own specialty now. It's a primary specialty in medicine. Okay. As far as funding goes, like I said, this is an issue. I think that if you work with your interventional radiology department, they will help you sort of overcome it. It really hasn't been a problem in the past. One of the things that we also did, if you have no money and if you have a really bad sort of IR department, or in terms of like the strength of that number of people and so on and so forth, what we did was we had a nearby med student, their IR interest group. So for example, in Chicago, we had a really big med school host an event where they invited a second smaller med school that didn't have an IR department. And that way, they had their IR interest group, their meeting got more traffic, and med students at a separate med school who would have otherwise never had experience in IR got exposed to it. And I think this is another sort of critical piece of information, right? We're sort of tracking all the IR interest groups around the country. These are your colleagues. These are people that you guys are going to kind of grow old with and see at meetings for the next 30, 40 years. We're trying to build this network so that, when we are all in residency and when we're all in training, or when we're all attending and whatnot, we'll have sort of a network already developed of like-minded people that we'll all be able to help each other as we go on in our careers. So that's all I have. Feel free to contact me anytime. We can talk about questions sort of at the end of the presentation.
Chat.
All right, thanks, Alok. Next up is, help me out, Nick.
Erica Alexander.
Okay. So Erica, I'm going to give you presenter privileges. And by all means, for the attendees, if you guys have questions, feel free to put them in that question box. At the end, we'll give you a link, both if you're interested in signing up to be a SIR med student member, and if you are interested in getting lectures or information on that IR interest group cookbook. So Erica, we see your PowerPoint. The floor is yours.
Okay, great. Let me just get this up and running. So I just want to point out that I have my email address on the front page, so if anyone wants to jot that down. Just for a little bit of background, I'm at the end of my MS3 year over at Brown. I was part of the 8-year medical program here, so my avenue into interventional radiology is probably a little bit unusual. I started doing research in the department my junior year of college, and it was mostly by virtue of needing to have a science research experience in order to get my Bachelor of Science. And I ended up doing research with one of the people in the tumor ablation department. and was really interested in thoracic ablation, and that was my initial foray into interventional radiology. And I would go to new conference every day when I was in the department, and I would shadow other providers and really saw how diverse the field was and realized that I actually did enjoy the imaging component, and I enjoyed being able to look at procedures and see that there was a fair amount of patient interaction. And when I showed interest in the department, a lot of the other attendings kind of showed an interest in mentoring me as well, and I was fortunate enough to meet with Dr. Ahn, who's the fellowship director for VIR over at Brown, and he encouraged me to get involved when I transitioned over to medical school and helped start an IR interest group. So that was kind of how I got this role and was able to have a lot of wonderful opportunities both at the school level and at the national level as well. So just briefly in terms of how Brown implements IR in the various years and through various clubs, in the preclinical years, our exposure to IR is pretty minimal, and that's something that's unfortunate and something that we're really trying to change in the coming year. So we do have some exposure to radiology attendings and even some of the interventional radiologists through things like small groups. So when we have things like our neurology block or our pulmonology block, sometimes these attendings will volunteer to help. So my point for this is to encourage your attendings at your school and your department to try to find ways that they can get involved in the preclinical years, because I think that one of the major disadvantages that IR faces is that we don't get into the curriculums early enough and people aren't exposed to it early enough. So one of the great things you can do is really encourage attendings to talk to first and second year medical students who otherwise wouldn't really know what IRs do and what the scope of the field is. The other thing that we have done is we open up our IR interest group events to all of the various years. We'll really advertise quite heavily for these events as well. During the clinical years, Brown does a much better job providing exposure to IR. So we have a dedicated IR elective that people can take during their MS3 or MS4 years. And you can take it for 2, 3, or 4 weeks, which is really phenomenal because you can get quite a broad scope of procedures in. And for medical students that show an interest, the residents really let you help, and or the fellows for that matter. And I've been able to do first assist on a lot of procedures, which has been phenomenal. The other thing that Brown does is a longitudinal in IR. So this is a really great opportunity, and if this isn't something that you have at your schools, I would really encourage you to talk to your medical education department and advising staff. What the longitudinal at Brown is it's a 6-month clerkship where you spend half a day in the clinic setting. So in my case, I spend it in the vein clinic over at their outpatient site. And I'll see a lot of varicose procedures, but I also get to see a lot of patients pre-op or post-op from their procedures. So you get the follow-up of things like uterine artery embolization, even some of the neuro interventions, which is really phenomenal to get that varied perspective of what their life is like and the scope of their practice in terms of clinical encounters with patients. The other thing that we're able to do during our diagnostic radiology elective is that we're able to rotate through the interventional radiology department. And if students display some sort of interest in a particular field, they'll allow you to spend a couple other half days or full days in that department as well. So even if you guys don't have a dedicated IR elective, I would really recommend stating some sort of interest in the field. And this actually goes for every clinical rotation you do. So I'm the kind of medical student who, as a third year, will tell my attendings on pediatrics or OB-GYN or any of the other specialties I'm interested in that IR is the field that I want to go into. And for the most part, people are really receptive, and they'll encourage me to follow patients and procedures if they're going to have any, and also to go to the radiology department and go over scans with them, which is something that I really enjoy, and I think it really enhances my learning experience on those clerkships as well. So my key point is I would be the kind of med student that really advocates for your interest in a particular field, because I think that a lot of people are scared to assert some sort of interest in a particular field, but other attendings understand that you're probably not going to go into everything you're rotating in, so it's a perfectly fair and acceptable thing to state your interest, and people will really accommodate that for the most part. The other thing we've done at Brown is we established our IR interest group in 2011, which was my first year at Brown Medical School. And the key was having a really wonderful faculty advisor, who in our case is Dr. An, who's really motivated to increase medical education and is always eager to help mentor medical students and encourages them to come shadow him in the IR suite, which is phenomenal because it's a great way for first years to see what IRs do before they get to their elective blocks during the clinical years. So what we did was we applied for official club status from the medical school, which was fairly easy. There's an activities office there and also the medical education office at the beginning of every year emails out all of the medical student members about starting new clubs, and there's actually funds provided. And granted, these funds are rather minimal, but they do cover things like food, and I'm sure as a lot of you know if you're listening and you're medical students that if you provide food, medical students will show up and participate in events. So that's a great way to do that. And the other benefit of being an official club is that it also lets host events at the medical school, which becomes important for things like our regional symposium that we've been able to carry on for the last 2 years. The other thing that I would really recommend for all people with IR interest groups is really to provide leadership representation from every class year. So what we've done is every year in every MS1 class, we always establish someone who's interested in IR and has leadership experience, and that person stays on throughout the duration of their medical school education. So right now, I'm an MS3, we have an MS2, and we actually have 2 MS1s who are involved in our club. And the great thing about that kind of setup is that you always have someone in the pipeline who knows the ropes and knows how to establish events, and it really keeps the interest in the club going on for the future duration, even once the current leaders end up graduating. So this is just a list of some of the events that we've held over the last couple of years. We always have an introduction to VIR. We also have lectures that correlate to what people are learning at that given time. So we actually have our next IRIG event tomorrow that's going to be led by one of the neurointerventional radiologists in our department, and that's because the first years are actually on their neurology block, so we thought that was really applicable. We've also done other interventions like carotid stenting, uterine artery embolization. We try to get a residency panel in yearly because it's nice for medical students to be able to ask advice. And we've also had a day in the life of event where we actually have medical students go to the hospital and look at readout and tour the IR suites, and we have them there for dinner and they ask questions, and it's great because they can interact with fellows and other faculty in the department, and that's always really well received. And the biggest event that we throw every year is the Brown VIR Symposium. So what this is, it's a local regional conference that we established 2 years ago, and we've had participants come from as far away as Florida. And what ends up happening is it's a 6-hour half-day symposium on a Saturday, and we have faculty members from the department come and speak about various interventions and treatments. We also have a brief history of IR, which is interesting for people who don't know a lot about it. We also invite residents and fellows to come speak, and they'll speak on various panels. They'll also talk about research experiences that they did as undergrads. They'll talk about what appealed to them into going into the field. We also have a 1-hour simulation session, which is pretty awesome. We have RFA stations, or radiofrequency ablation stations, and we procure calf livers, and people can play around with the probes and look at the ablation zones, and that's always really well received. We also have biopsy materials. We have stents and wires and catheters, and it's great for people to get this hands-on exposure, and it also makes it fun because it's not just sitting through lectures for 6 hours straight. So just in terms of my key pieces of advice for everyone is really to identify an enthusiastic faculty member. And I think that's probably the thing that I've been most fortunate to find during the past couple, or over the past 5 years for that matter, is that I have phenomenal mentors that have provided me with great opportunities to be involved in research and also activities at the club level, at the school, and also the national level with SIR. I would also encourage all of you to be mentors to younger medical students. I think that the greatest thing is being able to spark other people's interest in the field and really serving as someone that they can come to for advice, and also allowing them to have leadership opportunities within the clubs. I think that really makes people passionate about the field and allows them to have ownership over their involvement as well, which is great. I would encourage students and faculty members to both shadow and provide shadowing opportunities, so whether that's one day in the IR suite or half a day, or if it's doing an elective, I think it's a great opportunity because, as Alok had said earlier, this is really a field that sells itself. So I think that if you provide people with opportunities to see what IR is like, a lot of the appeal is kind of a natural next step. And then I also have the SIR website up there. So SIR medical student membership is now free, and it's a great way to receive our newsletters, also find out about things like these webinars and when they're occurring, and just kind of be in the loop. And also attendance at the national conference or registration is free for medical students. And my plug would be that if you're in the area of one of these conferences, or even if you're able to take time off and go, they're really a phenomenal networking opportunity. They're a great way to see what innovations are occurring in the field, and a great way to see how other schools are implementing IR into their curriculums earlier, and with the new clinical pathway, it's great to hear about what programs are going to be having them and what those programs look like. And I would encourage all of you guys to really think big when you're going about this. So whether it's a regional conference in your area, or whether it's starting a new IRIG at your school, or really just trying to integrate the IR department at your hospital with your school and establish that relationship, I think the more you can do, the better. And I would encourage anyone with any questions to email me at any time. I'll be the Med Student Council president for SIR this coming year, and Nikki is our resident chair, and we're always available to answer questions and to talk to you about involvement in the IR Med Student Council. So thank you.
Okay, can everybody hear me? I don't have a nifty PowerPoint, so I'm just going to touch on a whole bunch of other things that were not said previously. I'm Nikki Zimmerman. I'm a fourth year at SUNY Upstate and will be going to UVA for their IR pathway next year. One thing I think both Alok and Erica mentioned was trying to get hands-on things, and I really think that's very important to teach students ultrasound and micropuncture technique, and so they actually are able to see it with their own eyes rather than looking at what an ultrasound looks like on a PowerPoint, because it's not quite as engaging. So that would be tip number one. Number two is work on combined lectures, not just pairing up with Gen Surg or OB/GYN for a single lecture, but at our school we came up with a diabetes awareness week. So we had a different interest group present each day of the week on how diabetes affected their specialty. And so we had a huge presentation from IR on all the various ways that IR can treat pathology affected by diabetes. Set up regional conferences, and not just with your school, work with the schools in the area. So at our school we had lecturers from Albany and UB and the University of Rochester and UMD&J, as well as Upstate. So really trying to bring in everybody in the area in order to get a large number of students there. As Andrew Bunny mentioned, the lecture series is a set of lectures for you to just go up to a professor and be like, hey, we really want you to present to our IR interest group. Can you present? And they say, yeah, but then they come up with like, I don't have a lecture or anything, and then they run out of time to make one. So this is a pre-made set of lectures for you to use to present to either your interest group or during an MS3 or MS4 elective on IR that are standardized. And if you would like them, you can email sir.students@gmail.com and we can get them to you. Also, if you are interested in the IRIG roadmap, which is how to establish an IRIG at your school, you can email the same email address if you don't have one. It's got troubleshooting in there as well as ideas on different lectures. I'd encourage all of your members to do an away elective. Even if you think your school is the #1 in the country, it's good to get an outside perspective and see what IR is like at a different institution. On the RFS website, it's rfs.sirweb.org, which is on the slide that you can see. On there is a list underneath the medical student section of every single IR elective that you can take as an MS3 or an MS4 at every single institution across the country, when it's offered, how many weeks it is, whether you apply for through VSAS or through their home institution website. So I would really encourage everyone to go and do an away elective and encourage your members to do the same. That's the website there, so you can find it underneath there in the Visiting Students Clerkship tab on the left side. There you go, Dave. Thank you. And then one big thing is you're hosting all of these amazing lectures on IR, and you're offering these great, insightful presentations on what IR is. Invite the pre-meds at your school. So most medical schools have an undergrad affiliated with them. So it's as easy as contacting the pre-med group at the undergrad and inviting them to your lecture. As Erica said that med students come for free food, pre-meds definitely come for free food. And this is a great way to find out about IR prior to getting into medical school. And it's a whole group of people that we haven't yet started recruiting from. So I would encourage you to broaden your horizons and invite pre-meds. So that's all I wanted to add in because I wanted us to have time for questions. So I think we're going to open that up to questions now, Nick. Is that right?
Yeah, we've covered a lot of stuff. Do any of you have any questions? Or I guess if you're all muted, you could use the chat function, and we can field your questions that way.
Or if you guys raise your hand.
Someone just sent me.
Yep. Go ahead.
Yeah, someone just sent me a question, so I'll just read it out loud. They asked, if you do an away elective in IR, will you be allowed to get hands-on experience? I had been told by a lot of students that went on aways that they were not allowed into the IR suites. So from my experience, I did 3 IR electives, 1 at my school and 2 aways, and every single one of them on day 1, I was in the IR suite, hands-on, and by the end, I was doing full procedures nearly on my own. And so I would highly encourage you to do an away. I can't guarantee, obviously, that you'd have hands-on experience, but if you are looking into a program specifically, you can email me individually, and I can help find a program that may have some attendings that we're already familiar with that might give you a great experience.
Nikki, how many team members did you do at our place?
I think it was like what, 20? Oh, primary operator, I think about 15.
Okay.
I think I did 22 total and 15 on my own.
All right. So that tells you that there are certainly places that allow, a fair amount of autonomy. So it may not be a lot of places, but as people get more comfortable with you, and especially as you do multiple sub-Is, I think the opportunity is there. That's Dr. E, by the way. Back. I'm back. I finished my case.
So Dave, I don't know if you can click on it. People have sent in questions. If you see those little question marks, I can only see the ones that were specifically sent to me, not to SIR staff.
Yeah, I got one here, Dr. B. I'm going to let you, I don't know if you can comment a little bit. I know they had they were like trying to do a survey on cataracts, but we have a question. Can you address some of the stigma and concern about radiation risk for interventional radiologists?
Yeah, so I think certainly if you can reduce your, as low as reasonably achievable is kind of key. And I think the radiation risk in general probably overstated in the sense that they base it on Hiroshima, Nagasaki, and kind of and Chernobyl. And so obviously those are massive blasts of radiation. So there's really not been any good population data studies to showcase an increased effect. Certainly we think there's probably more posterior capsular cataracts, and they're doing a study at SIR to kind of look at that, and they've done studies on that. So certainly you want to do everything to reduce your radiation. Dr. Marks, Vicki Marks from UUSC had a really great presentation at the SIR meeting this year, showcasing how she had a couple pregnancies with appropriate therapy. Appropriate kind of protection. She had 2. She wore lead with a 1-inch layer right around the pelvis around the baby, and her fetal dose was almost nil. So again, the radiation is probably not the main issue. I think more of an issue would be kind of the lead and the weight of the lead that can over time cause some, some issues. So you really need to be in shape and kind of work on your core, I think, and that's what I advocate. And so in general, I think the radiation, obviously be out of the primary beam, do everything you can to reduce it. There's the imaging equipment is getting better and better. The lead is getting lighter and lighter, and still effective. And there's things like RadPad, and you have to be smart. But I think you do those things, your dose can be fairly low. And then if you mix in clinic, and consults, et cetera, where you're doing a lot of non-procedural stuff, that reduces it. Then image-guided procedures, so using ultrasound or even MR or CT also reduce it as well. So the combination of all those things, when you mix it in your schedule, can reduce it. So yeah, I mean, you have to be smart, but I think it's overblown in general.
Okay.
Just adding on to that real quick for any females that are out there, there's an abstract at SIR, at SIR this year that showed that there was no increased risk of radiation during pregnancy, so you're like safe to have babies during pregnancy is what they showed. Just to put that out there.
I got another question. Leanne asked, I'm going to answer this one if you guys don't mind, and then get some thoughts. Are any of you interested in an academic career? If so, how do you think you will have the time for research, and what type of research might you pursue? Basic, clinical, etc. I'm not sure if you mean at the medical student, resident, or full-blown attending level. I can tell you as a resident, the IR months are extremely busy, more so as a surgical, like the surgery set schedule, for those that don't know, very busy hour-wise, but especially on the diagnostic months. Right now I'm on fluoroscopy at the VA, so our typical days are 8 to 5. So I have ample time to work. Actually, there was an IRB meeting this morning that was very easy to go to, and as far as type of project, it's whatever you're interested in. There's opportunities there, and as long as you have good, organizational skills and time management skills, there's ample opportunity to do clinical, basic science, translational research. I don't know, anybody want to add anything?
I think one of the important things to remember is that as a resident, the ACGME requires every resident to do a research project of some kind, and that can very easily be IR. As IR moves into a primary specialty, there will start to be this change from developing all these new interventions to actually proving them useful to the medical community through research. So I feel like interventionalists as a whole will be very motivated to do research and actually prove that there is a statistical advantage to using a minimally invasive technique besides a surgical or even a medical technique. So I think it's definitely available for someone who's out there to take advantage of research.
Yeah, no, I have to echo, Dr. Vacchair, I have to echo that. There's been some pretty impressive grants awarded to interventional radiologists, and there's some very good bench and clinical research. Dr. Mizra has a very busy lab where he's looking at, he's looking at, restenosis. So one of the problems when we balloon dilate or put a stent in, these stents go down. Unfortunately, they don't stay open forever. And it's because of the body scarring response. So that's a holy grail. If we could figure out how to prevent that, drug-eluting stents is a way in the right direction, but it's not perfect. So if we could figure that out, that'd be huge, right? Cancer itself, targeting therapy into, cancer is a problem. If we can figure out how to do that, again, huge inroads into changing the way medicine is, right? So there's a lot of opportunities, for things that are just on the cutting edge, whether it be how to manage pulmonary embolus, how do we prevent aneurysms from growing? How do we treat aneurysms? Is there a better way to do it? So a tremendous amount of opportunity. And as we have clinics and follow these patients longitudinally, more and more questions come up on how to fix these things. And so certainly research is a huge initiative. How can we compare renal ablative therapy versus partial nephrectomy? The gold standard. So we need to find those trials, as you said, and can pursue it. And IR has been very prominent in this, in the CORAL trial, which is renal artery stenting trial, randomized. CLEVER trial, which is a claudication trial, randomized. Again, National Heart, Lung, Blood Institute, and NIH trial. So a TRACK trial, $10 million trial looking at DVT thrombectomy. in a randomized fashion. So all these are IR primary and principal investigators. So many of these trials are being driven by interventionalists, and so there's a lot of opportunity for students who are interested in that stuff to take that on.
Sorry for the typing again. All right, any other questions, or if anybody wants any? All right, here's another one. So this is a question. Actually, Nikki, I'm going to send this to you. Basically, how do the clinical/direct pathway programs appear on ARIS, the application thing?
So as of when I applied, which was this past year, there was only 2 of them in which you could apply to on ERAS, and they showed up as, one of them showed as direct and the other as vascular and interventional / diagnostic radiology. Other ones you can talk to the program director and tell them you're interested. For instance, UC Denver doesn't have it on ERAS, but you have to fill out a separate form for them, for their program director. I would anticipate that over the next year there may be more adding to be able to fill it out on ERAS, but any program that you're specifically interested in, I would contact the program director for it.
And I would probably actually, just to add to that, I'd probably contact the fellowship program director. I think that'll be higher yield.
Dr. V, I sent you a question. I'm not sure if you can see it. How do other specialties view IR with respect to especially like vascular surgery, where there might be some turf battles?
Meaning our competitors or our...
I think it's a 2-part question. One is more general, and then the second part is respect to competitors.
Okay, so how do other specialties view interventional radiology? So I think it depends. So if interventional radiologists are kind of practicing in a kind of older model where they're not seeing the patient in preoperative consultation or following them longitudinally or dealing with the the patient issues and kind of taking care of the patient, well then not in a good light, right? Because they're not practicing the way medicine patients aren't being taken care of appropriately, performing invasive procedures on patients without a full workup or knowledge of what's going on. So that doesn't fly with anyone, patients or otherwise, right? So that can be an issue. Now the places that have IR where they see the patient, admit them to their service, round on them, order their scans, labs, follow them, and really take care of the patient in general, and know their disease and are always available and and willing to help out. Those groups are very respected in the hospital amongst referrings, et cetera. Now, it is our responsibility to educate referrings about the diseases that we manage to treat and really own and manage those diseases. So, so it really is a 2-tier thing. It depends on where you're at and what kind of IR practice they have. So that's the way. And as far as competitors, I would say that really medicine with competition is improved. So neurosurgery and spine surgery and PM&R and anesthesiology and IRs and neuro-IRs all being involved in pain interventions and spine procedures has only enhanced the field in a lot of ways. Okay, it brings a lot of different silos and makes things move faster and ideally collaborate. In endovascular therapies, peripheral arterial disease, whatever it may be, the fact that cardiology, vascular surgery, and IR are all involved in it, we bring different things to the table, and I think it's valuable. Now, if the interventionalist isn't able to manage the disease, admit the patient, or get their own referrals, well, then then they're not going to be seen as the same light. Now, if you're kind of doing all that, providing quality care, and and then I think you're respected. At the least you're respected. Certainly, there's going to be some turf issues here and there, but if you're doing a good job, providing a good consultative service, know your disease and own it, I think in general, you're going to do well, in general. But you really need to know the disease, and that's why these integrated training pathways are there. And really, as much as you can, you should try to collaborate, but, and a lot of times IRs are not necessarily, bringing anything to the table or referring patients to the other services. It can't be a one-way street where their specialists are referring to you and you don't refer to them. So really it has to be kind of a combined kind of route where you're referring patients that you can't do or you need help or guidance, but you're seeing in the office, you're getting that consult.
So in essence, I think what Dr. V is saying, collaborate from a position of strength so that other people know that you're going to do what you're going to do, whether or not they're involved. So it's better for everyone if they are involved, that sort of thing.
All right, we got time for one more question. We're a little over. Dr. V, if you don't mind leading again, since we got you. As IR becomes more clinically oriented and focuses on longitudinal patient care, what proportion of the interventionalist time will be spent in the IR suite versus seeing patients in the clinic?
Really good question. That's a status of evolution. So if you look at my own practice and a lot of my colleagues, what we're doing is at least one day of office clinic work, 1 to, sometimes 1.5, right? But at least one day roughly. I've spent about 2 to 2.5 days roughly in the lab, doing cases like Tuesdays and Wednesdays. So my schedule is Monday morning office, Monday afternoon procedures. Tuesdays and Wednesdays are my full elective procedure days where I can schedule my elective cases, and that's why today I'm doing cases. Thursday morning I kind of have, I may do inpatient consults. So we have a doctor who does inpatient consults during the day and just sees floor work and does floor work. So I'll do maybe a half day to a day of that. So about 1 day, 1.5 days of clinic, 1 day of kind of floor work, and about 2.5 days of procedure time, roughly. That's kind of where it's evolving. Some may do more clinic than others, and so that's roughly it. But at least a day of clinic, maybe up to 2 days, and then floor consults if you have an inpatient side. And that's, we're still evolving. We're still not quite, where we think we'll be in 5 years. So the specialty is rapidly evolving in that regard.
All right, Nick, you want to close us up, Nick?
Yeah, we just want to thank everyone for tuning in. Hopefully we've given you some good ideas and things to take home to your own programs. And please follow up with the links that we've provided and email addresses. We'd love to hear from you and hear specifically about your successes, hopefully, but also your struggles in promoting IR education at your home institution. And I just want to thank all the panelists for contributing their time tonight as well. And Dave, thank you for helping us get through the technical factors of the webinar and fielding questions as well. So thanks, everyone.
Sure, and I'll just say real quick, sorry I forgot, if you guys want to rewatch this webinar or share it with any of your co-students on our main page, rfs.sirweb.org, it will be part of this our IR Webinars YouTube channel. You can find a bunch of other, our past webinars will be up there, so if you wanted to rewatch this, you can find it there, as well as the med student section if you want or interested in getting those links. Otherwise, go ahead and email us. All right, take care. Thanks, guys.